Bring it on. Oh, hey, Chris.
Hey Chuck, how are you?
Fantastic. It's the end of a nice busy day and a lot of excitement, a lot of things to talk about. I'm great.
This is great. This is abnormal for us to record at the end of a work day on a weekday, but we make time for it. Everybody asks how you make time for the podcast, and you just say that you do.
Yeah, with some days are early, some days are late, some many are weekends, but it's all good. It's all fun. It's all worth it.
Well, before we catch up a bit, tell us what we're going to talk about today.
Yeah, I think introducing the topic is maybe one lesson that we learned from our survey. We're going to talk more about our survey, and we're so grateful to those of you who took the time to complete it. But one of the many really, really good suggestions for topics um, is, quote, things too dumb to teach during fellowship, practical treatment approaches to a bunch of different diagnoses. And so we're gonna go through those one at a time, and I think it'll be fun.
Yeah, it'd be great, and it's the end of the fellowship year for some, and almost the beginning for others. So we'll roll in a few pearls for both of those different crowds, since this will be dropping in towards the end of July.
Absolutely. And I had a longtime listener, therapist friend, who asked a question, and I thought we should discuss it on air based on our last podcast, which was regarding the carpus, which I've gotten some good feedback on.
Oh, I had a couple of people in jest ask me what my favorite carpal bun was, fully knowing that we had talked about this on the air.
Well, that's half the fun. Anyways, Michelle is an occupational therapist at the St. Louis Shriners Hospital, and she asked me to explain how do you take out the pisiform and what do you do with the tendon? And she understands anatomy very well, but I sort of talked about my approach. When you think about removing the pisiform, how do you think about it?
Trying to think of the number of times that I've actually removed a pisiform, and I think I've done one.
Oh, interesting.
It doesn't come up for me that often, so I'm not the wealth of knowledge that you were hoping and expecting. I would just say I'm not sure. So how do you think about it?
Well, it's not a common procedure for me either. Maybe once a year, maybe less. I just, I think it's straightforward. It's one of the situations where the pizza form is always bigger than I expect it to be. I make an incision directly over the pizza form, trying not to cross the wrist crease. And in terms that Peter Stern would hate hearing me say, I shell it out. And longitudinal incision in the FCU work around the bone, protecting the nerve vascular bundle nearby, and just take it out. And then I do close the pisiform, close the FCU, and that's about it.
What's the FCU left attached to at this point?
Well, we should both probably know that, but I think it is attached to probably the pisohamate ligament, which I guess would be affected, and it attaches to a lot of investing fascia in the area. Does that sound good?
No,
Investing
that
fascia?
sounds right. I mean that was my understanding, but clearly I do not have. I'm not a high volume pisiformectomy surgeon. Fortunately, I'm very proud of that actually.
Dream. You
Uh,
can dream.
but I don't remember ever really doing anything substantial with the FCU afterwards. So clearly, it was not top of mind for me.
That's fair. Um, well, the survey was great, and I think I we talked on air about why we did the survey. We did the survey because I read a really interesting book about podcast and learning from your audience, and I'm going to try to we are going to try to apply some of those lessons, but we wanted to say thank you, and we got well over 70 surveys returned, and 43 of you left an email address. And so we are going to do four prizes or thank yous. Is that right?
Yes, we are. So let's just say, first, totally agree. Thank you to those of you that filled out the survey. And for those of you that left your email addresses, we are going to pick two. The first two will get the coveted, extremely limited edition upper hand coffee mug, which some of you may have seen on one of our fellows, Dan Hong's Instagram stories, because he finally received one. I guess the same day that you were giving one away to a to an avid listener.
Yeah, we can
And
talk
then
more about that. Yeah, keep going.
and then the second two will get probably never before seen by many upper hand backpack.
It so I'm not a huge like I definitely use a backpack or a sling bag or whatever all the time. I was a little hesitant. I actually used mine for the first time last weekend because I needed a big enough backpack, but not too big. It is a techie backpack with a lot of different pockets. It's really nice. And you tout the Upper Hand podcast by wearing it.
Yes, you may. Those of you in Carbondale, Illinois, may see me this coming weekend hiking throughout Giant City State Park with an upper hand backpack on. So just if you see it, take a picture.
Wow, I didn't know you were going to Carbondale for a big hike.
My wife's going out of town, so it's the opportunity to do something more outdoorsy with the kids. So we're gonna go up to Carbondale, and we don't have to go on and on about the merits of this place, but apparently they have amazing fried chicken that is all you can eat. So that's my draw. That'll be for dinner, but we're gonna do some stuff like archery and fishing and hiking during the day, stay overnight in a cabin, and do a hike on the way out. It'll be tons of fun.
You all kind of great stuff. National parks one weekend, state parks the next weekend. Unreal.
You got to take advantage of the amazing country that we have that is the United States of America, Dr. Goldfarb.
I want to start singing the Star Spangled Banner, but I don't think I'd do that to our listeners.
From sea to shining sea and everything in between. So let's get on with the. Why don't I pick two numbers for the coffee mugs, and you pick two numbers for the backpacks.
Okay, we're gonna do this sort of live-ish, but go ahead, pick a number.
And my options are like 1 to 43, correct?
Yes.
Okay, let's go 37.
Okay, 1 second.
Hopefully everybody's on 2x speed right now.
If they're not, they should be soon. That is, I'm just going to read the email address. I'm also going to follow it up with an email, robertashley.pearl@gmail.com.
Robert Ashley Pearl, congratulations on your coffee mug, coveted mug. And let's go with number 13.
Okay, give me a second to do a little math. This one is, if this is international, we may have to meet you somewhere. Um, this is Liren underscore Ophir, Ofir at yahoo.com.
Ah, yes. The old Yahoo address. Haven't heard one of those in a while.
Yeah, yep. Okay, well, why don't you do two more because I'm looking at them. So,
All right. So to make your life easy, let's go to 17.
okay, fantastic. This is Joseph Porta or Porta Joseph at me.com. Excellent. And that's a backpack.
And drum roll, number 42.
All right, let's go. JP Walsh 98 at comcast.net.
Okay, well,
This is
congrats to
fun.
all those folks who have won mugs and backpacks. I'm sure I'll get harassed by current and incoming fellows about said backpacks, as well as the coffee cups.
Um,
But congratulations and thank you everybody for filling out the surveys. Certainly helps us understand how you use the podcast, what you want to hear about. There's just so many good episode ideas here. We have to get more guests. We have to get our therapy friends back on the pod. Just a lot of really great topics to work from. So thank you.
Thank you. Hey, Chris, The Upper Hand is sponsored by PracticeLeap.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. Finding the right job doesn't have to be. Join PracticeLink for free today at www.practicelink.com/the upper hand. I actually did do that completely from memory.
I don't challenge myself in ways that you do. You're always challenging yourself.
Just a stretch position there. Trying to work hard. I will say we're trying a new thing, and we're trying to do some feats of strength, and with our current clinic team. Last time in Nerve Clinic, we busted out some push-ups, and tomorrow I'm going to get embarrassed because we're going to have to do pistol squats, and it's going to be impossible.
I'm glad I'm not in your clinic. Who won the push-up battle?
It depends on who you talk to. Form versus quantity. Offline conversation.
Classic struggle. We have a guest in town for a couple weeks.
We do. Dr. Anthony Verdonk is visiting us from Belgium. He is here for a multi-week experience, spending a lot of time with me. Got to spend some time with you today. He's doing a bunch of traveling fellowships in preparation for his staff position back home.
Yeah, it was really, really fun to meet him. And I think today was a super weird day, just unusual cases, packed. It was a busy day. And yeah, it was very fun to have him. And hopefully he'll come back next week.
Yeah, that'd be a great time. We had a nice day in my ASC neck of the woods in South County and had to fully utilize the block time, put it that way, which was good. And then Anthony came over for dinner on Monday night. I cooked some stuff for him and Dr. Burks, and we had a good time.
Love it. So before we jump into things too dumb to teach during fellowship, should we share a few pearls for incoming and outgoing fellows?
Yeah. So what's the biggest thing that you would advise if you had one or two things to advise a graduating fellow as they start to think about these frenetic last week or two of the fellowship? What could they potentially glean now and what should they be thinking about? Most people take at least a couple of weeks off before starting a position, sometimes 6 to 8 weeks. What should they be doing during that time to prepare themselves for practice?
Well, I might say don't do anything during that time to prepare yourself for practice because it's your last opportunity to sort of not think about practice and enjoy it. And there will be plenty of time to, process, get better, and jump in. What about, would you tell them to do anything specific?
I think it's probably think about what they want out of their practice, because that's probably the biggest thing that they're going to be concerned about. Is if you don't try to set goals now, or at least think about what you want to check in a year, 2, 5 years, to see if you're heading in the right direction. It's very hard once you're in it. Once you're in the thick of it, and clearly it's hard to know what's feasible until you're kind of in the job. But I think it's nice to think about, have some goals for yourself, potentially some metrics as well.
I think that's good. So you're sort of talking life planning, career planning, big picture thoughts, and then reassess once are in the mix, so to speak.
Yeah, because I mean, once you're in the weeds, you're going to be in the weeds, and it's hard to pull yourself out of it. Yes, you're not going to be as busy in your first few months, first couple of years compared to when you're full swing in practice a couple of years in. But it's hard to zoom out and kind of think about long term goals. Even now, like I try to check in, think about every year. I mean, we're coming up on 10 years after finishing fellowship, and I haven't truly. I've tried to reassess, tried to change the way that I do things a bit in terms of big picture stuff. But I'm honestly overdue for a very long think about that.
Yeah, just carve out a couple hours. That'll be easy.
Easy to do, no problem.
So Dan and I talked a little bit about this today, as I reminded him that his biggest loss from completing fellowship in preparation for his first job is that I can't go with him and retract for him. And therefore, it's the things that seem simple during fellowship with an experienced hand across the table will not be so simple when he's in practice. And so the classic teaching, and we have said this before, we will say it again, is overschedule your cases so that you get them done on time.
Yeah, so it's interesting. If you look at, we get these utilization metrics every month, right? And you look at the people who overschedule in our hand division, and the busiest people are the ones that overschedule the most, which is, I think, truly interesting. I try to be somewhat. I'm like a third overscheduled, a third appropriately scheduled, and a third underscheduled, so it all kind of washes out. So I'm like 35, 33, 37, something like that. So it works out okay, but
That's
um,
that's good. That's kind of where you want it. I think maybe a little more in the green, so to speak, but that's pretty good.
I underschedule some cases and intentionally overschedule others, fully knowing that it's going to work out as the day goes on. But like in my ORs on Tuesday mornings when I'm running these two rooms, I try to push the pace as much as possible early on so that we have ground to give later on. That's just what's worked for me.
Yeah, I think when you are kind of mature in your practice, the goal is just to be done at the when the day is done. In the sense that if you need to be done by 5 o'clock, be done by 5 o'clock. How you get there is not so relevant. But that's a little bit pie in the sky, and I don't, I think that as you start out your practice, you should focus on each and every case being scheduled appropriately and done appropriately, which means add some extra time.
Yeah, patient care first, of course. You have to be happy. Obviously, you want the best technical results you can have, but the other things are important too. That's a great pearl. Do you have any advice for somebody coming into fellowship? How to get the most out of a fellowship?
Yeah, I mean, look, it is a great year. It will be a great year. Our fellows, and I'm sure every fellow across the country, you have so much to learn, and coming in with a positive approach, a want to learn approach, a want to do as much as you can possibly do approach is really important. This is the foundation for the rest of your career. Well, clearly interpersonally, but more importantly, the facts and the experience. And man, suck it in, enjoy it.
Yeah, I mean it's hard because for example, we have a very busy fellowship. There's no getting around that. We like to think that we have a pretty incredible educational product, but it is a busy time. There's very little downtime. I think it's about for me, and this is a personal thing. It's setting a routine where you are able to have some regularity in your schedule. The thing I tried to do was an article a day, just something new a day, like whether that's a part of a chapter or an article, knowing what to read. And that's where the nice part about having things like the Stearns Classic Readings is it gives you some kind of framework, but an article a day. And then the other thing is just figuring out as you're into the fellowship when you have pockets of time where you actually have the energy to do things like read. Because I was all of residency, I was a night owl. But then when I got to fellowship, that really had to pivot and change because I was dead tired when I got home, and I obviously wanted to spend time with my wife. So we needed to check in and stuff, and then I was just tired. So I just pivoted and became a morning person. Just woke up earlier and did some work then in the morning, and that's still how I am now.
Yeah, I've definitely turned into a morning person, like 100% morning person. My advice for both incoming and outgoing fellows is to stay humble. And it means different things for the two groups. So I say for outgoing fellows, um, being a surgeon's a tough job. You can do everything right and not get the outcomes you want. You can experience suboptimal outcomes when maybe you could have thought about things differently, and it's humbling. And you have to know that, and you have to deal with that. You have to make phone calls and talk to people, and so it's a tough. You've chosen a tough career, but there's so much reward there that it's all worth it.
It's tough. It's incredibly rewarding. But yeah, there's no we'll get them next time. Like you got to be as perfect as you can be, especially for the routine stuff.
Yeah.
Like you have to be on your game all the time. And I think that intensity is what, and the adrenaline and the endorphins that come with it, that's what it draws many of us to it. But it is also the thing that can, kick you in the teeth.
Yeah, before we talk humility and incoming fellows, I think I've used this analogy, but I'm not positive. So, many moons ago, I played soccer and did so in college, and I was a goalkeeper. Have I said this? I don't know if I have. Um,
You've dropped this fact on the pod before. I
not
don't know where you're going with it.
not the fact. The point is whether you're a hockey goalkeeper or a soccer goalkeeper, um, if you give up a goal, and perhaps a goal that you wish you had not given up, you have to immediately forget about what didn't go right so that when the next shot comes, you're prepared to stop it. And I would say the hardest part of our job for those going into practice is having a case perhaps not go exactly as you wanted, but being able to process that, maybe put it aside and process it more later, but then give 100% of your attention to the rest of your surgeries that day.
That is the terrifying thing about doing a big case at the beginning of the day, or having something else, or having two rooms, or something like that. One of my former mentors and one of your former partners, Rick Wright, would say he liked to do the downhill skiing. He liked to do the big case in the beginning of the day and then do all the small ones. I can't do that. That doesn't work for me because if something doesn't go exactly the way I want it to, I'm going to fixate on it. And yes, you're right. You have to have the short, have to have the amnesia to get over it and do the best you can for the rest of that case and whatever else you have the rest of the day. But you definitely need to reflect on that case. And it's just so hard to flip that switch and go from like, I'm just going to do the best I can, forget about that, you know, that time when it didn't go well. and then move on to saying I actually need to reflect on this so I can be better. Because all of us, as much as you say you have to have a short memory, we all reflect on our most recent complication, and our practices are shaped by our most recent complication.
No doubt, no doubt. As far as incoming fellows, show humility. And what that means to me is, you may think you are an outstanding arthroscopist or a perfect um, provider of a wound closure that would make everyone sing. But you got to be open to different opinions about what your opportunities are because you are here in fellowship to learn, and there will be opportunities to learn. And so be humble, be willing to have an open mind, and again, soak it all in.
Yeah, clearly. I mean, as accomplished as you are to get to your fellowship, the new place you're going to doesn't know you. They've never seen you operate in most cases, unless you're staying after residency. And even after residency, you may not have touched a tenotomy in a year because you were doing everything else in your residency. So yeah, absolutely, stay humble. Mine would be to stay hungry. Like realize that, like you said, this is your entire. You have 1 year to learn your craft that you're going to work on the rest of your life. So it is as much as you think, hey, I think I got this. Continue to stay hungry. Look for more reps. Look for more opportunities to learn. Obviously, balance that with taking care of yourself and ensuring that you have as much time as you can to recharge and reflect. But stay hungry.
Love it. Before we jump into maybe some rapid fire discussion of things too dumb to teach during fellowship,
I
we
don't think
should,
they're too dumb. I just wish I had actually seen some of these things during fellowship.
well, that's true too. We should thank our other amazing sponsors.
This podcast is sponsored by Checkpoint Surgical, a provider of innovative solutions for peripheral nerve surgery. Join Checkpoint in Las Vegas on October 24th and 25th for an advanced course on treating spasticity from the elbow to the fingers.
Hosted by Checkpoint Surgical and led by expert faculty doctors Peter Ree, Kyle Chepla, and Kitty Wu. This course focuses on integrating nerve-based procedures like selective and hyperselective neurectomy into your surgical approach with lectures, cadaveric dissections, and interactive discussions. It's designed for practicing hand surgeons and fellows. There are only a few spots left, so register now at nervemaster.com.
Nerves in Vegas. I can't think of something more exciting than that.
It's true. Summer League basketball in Vegas has been fun, but nerves in Vegas might be more fun.
As we get to well, maybe in a few episodes, we'll have to have your special NBA preview and predictions. But
Let's do it.
So let's get into this. So the request was, as you said, things too dumb to teach during fellowship, practical treatment approaches to a list of conditions, and then the role of injection, aspiration at each site, threshold for surgery. I think people are all over the map with these. For example, Greens advocates aspiration of retinacular cysts, but I never poke a needle there out of fear for digital nerve. So the conditions that were requested: carpal boss, retinacular cysts, mucous cysts, occult dorsal wrist ganglion, tennis elbow, olecranon bursitis, and I'm going to add FCR tendonitis because I didn't know that existed until I was in practice.
True. FCU can have tendonitis too, and I always scratch my head.
So what are your pearls about carpal boss? Can you give us a brief description of what it is, how it might show up, and how you treat it?
Yeah, carpal boss is a prominence typically at the base of the third metacarpal. It's an enlargement of both the base of the third metacarpal and the distal aspect of the capitate. It's almost a extra bone formation, possibly related to mobility or who knows why you get a carpal boss. Many times they're just a bump, sometimes they're symptomatic, and sometimes the extensor tendon can flip-flop over the boss. I try like hell not to do surgery. I'll do just about anything to try to avoid surgery, whether it's splinting, corticosteroid injection, but occasionally you end up operating. What about
What
you?
are you in? What are you injecting? I mean, where are you injecting? With the
Yes,
CMC joint or the
yeah,
overlying soft tissues?
the CMC joint, which is theoretically right in the middle of the bump, because it's where the two joints come together. I mean, the two bones come together to create the joint, and the joint is just it's almost like these are osteophytes in an attempt to stabilize the joint. But again, I don't know. I don't think anyone knows why it happens. But steroids can sometimes do the trick. Not always by any stretch, but it's worth a try.
So you've tried, I guess you said everything. So splinting, I'm assuming a topical anti-inflammatory, a corticosteroid injection. benign neglect, trying to counsel them to leave it alone, and it just keeps bothering them and they are fixated on something. What the heck do you do in surgery?
Before surgery, I lay a lot of crepe because this is one of those operations where I cannot promise it'll lead to resolution. During surgery, the goal for me is not a flattening of that articulation. It's actually creating a little bit of a crater, not too much. Um, and I think it really can work. It can do the trick. I do tend to immobilize patients for 3 or 4 weeks afterwards, which I think only can help. And sometimes you feel really good about it and you get the results you want. And sometimes you feel really good about it. And unfortunately, patients still are symptomatic. But they know that before going to surgery.
Is this 1 a year, 2 a year, 3 a year? How many of these are you doing?
One a year.
1 a year. Huh.
Yeah.
I,
Now, if they do have a subluxating tendon, I think the only option is surgery because I don't think if it's uncomfortable. But other than that, I really try to avoid surgery.
I think I've done one, maybe two in 10 years. So clearly we have different patient populations, or it's seeing more than I'm seeing it.
No, I think it's just different patient populations.
Well, I hope that helps. I don't have anything to add to that, to be honest with you. I really just counsel people in the same way and really hope it gets better with when we basically we're waiting it out. So we're playing chicken with this carpal boss and seeing who wins.
So next one is the retinacular cyst, and apparently Green says don't poke it. I do
The green
you
says to poke it.
Oh, to poke it. Oh, but yes, but the person who suggested this episode, honestly, we don't know who it was. They don't poke it because they're afraid of hitting the digital nerve. Do you poke them or not poke them?
So, just to backpedal, a retinacular cyst is a gang in the family of ganglions associated with the flexor sheath. Typically shows up somewhere between the leading edge of the A1 pulley and the palmar digital crease on the palmar side. I've seen them kind of deviate a little bit more distal, a little bit more radial or ulnar. I honestly try to counsel people out of doing anything because these aren't people. I have not found that these are people that are actually triggering at the same time. Some people who have triggering have the sense of a cyst there, but it's probably just the metaplasia of the A1 pulley that feels like a cyst, particularly for a trigger thumb. But for a true retinacular cyst, they're usually not triggering. They're usually not painful unless it's when they put pressure on that area when they're gripping or grabbing something. That contact of the whatever they're gripping with the cyst can become bothersome. I tell people not to do anything unless it hurts. If it hurts, then we can do something. And I'd give them the options of having it aspirated or having it removed. I won't remove it unless they've tried to have it aspirated, unless they've had this condition before and gone through the same thing and want it out. Um, I don't aspirate these myself. I actually send them for ultrasound guided aspiration, mainly from a workflow perspective.
That was an excellent summary. I don't think we're completely aligned here.
You poke them in the clinic?
Absolutely. And I would clarify. First of all, I don't recall ever hitting a nerve. If it's really radial or really ulnar, that's totally fair. Most of them are a little bit central, if not directly central. And I take a 25 gauge needle, I inject a touch of lidocaine, and then I don't really think I'm aspirating. I think I'm puncturing. And I poke them a couple of times, and they understand it may or may not work. And for me, it is almost always the complaint of grabbing the steering wheel to echo what you said. And if it doesn't work and it's bothersome enough, happy to do a small surgery. But it's again pretty darn rare. Maybe once a year. And there's a theme.
So I see your point. I think I could do an effective job at puncturing it and squishing it. But analogously, I don't enjoy aspirating dorsal ganglion cysts because I feel like I'm not actually getting the very elegant aspiration and beautiful, pullback of fluid filling the syringe like my mentors did during fellowship. I end up basically puncturing that thing, and if I'm doing it, it's probably already multiloculated, etc. And you end up puncturing it and squishing it, and you get some fluid back in the syringe, and you feel okay about it. I don't feel great about it. They may feel impressed that it's smaller now, but you're really just squishing it down because it's the combination when I'm doing a dorsal ganglion, it's kind of bracketing it within your fingers on your opposite side, and then using your needle in your dominant hand. I'm assuming, and that squeezing motion as you have the needle in it is probably what is decompressing the cyst, not the actual aspirate of the aspiration using your syringe. That's my experience. So if I can't get that satisfying of a result on a dorsal ganglion, I don't think I'm going to get it on the retinacular cyst.
I hear you loud and clear, but I would say sticking a needle in a dorsal wrist ganglion, and I inject a little lidocaine with a 25 gauge. I use a 22 gauge to attempt to aspiration, but I agree with you completely that rarely does the fluid come out in the syringe. But then you get the really satisfying pimple popping maneuver, and you get that ganglion fluid, and you just express it, and patients love it. They love it. You should do
I
it.
don't. Doing that in the office does not bring me joy. I will do it. I will do it. Okay, a dorsal ganglion cyst. I will do it. Does not bring me joy. And I was thinking about my list of conditions to see or exclude, and for the kindness to all of our partners, I did not put wrist cysts on there, but I darn near thought about it.
It's so funny. I think about that kind of stuff all the time, and there is some shared pain in what we do. There is
I
no doubt.
think I think if the hand surgeons won't see a ganglion cyst, then God, who will? So
Next up is occult risk ganglion, sort of building on what you just brought up. You know, occult ganglions, first of all, you have to have the suspicion that there may be a ganglion there because by definition it's not palpable. I use ultrasound to make the diagnosis, occasionally MRI if I'm not pretty darn confident that it's an occult ganglion. And if it's confirmed and if it's bothersome, I offer a surgery. I don't try to push people to sign up. More and more in my career, I just give people options and say, I'm not pushing it towards any decision, but here's a good option. I do think it's an effective surgery, but it's not up for me to decide whether the pain is, enough to warrant a surgery. It's up for the patient to decide.
do you even consider an aspiration in this setting if you see it on ultrasound? I mean, because I find this to be less than satisfying. I don't know. I don't think I've ever taken a patient with an occult ganglion cyst, dorsal ganglion to surgery. Mainly because if I'm having a hard time finding it and calling it occult, what about on the day of? Like, what am I looking at? Am I just going to expose their SL ligament and hope something's there? I don't personally love that.
1,000% yes. Yeah. So this is the great. I love this
So
teach
people used to say we don't disagree enough. So here we are disagreeing about literally everything.
on the things too dumb to teach during fellowship
Well,
episode.
clearly I didn't learn this during fellowship. So
So a normal ganglion, you make your incision, the ganglion's right there, you trace it to the SL ligament. With an occult ganglion, you just go directly for the SL ligament, and voila, there it is, really satisfying, and you always find it. And I actually like those surgeries more than the big monster ganglion that you're kind of fighting around.
I would rather have them go for an image guided aspiration, or I just do a rated carpal steroid injection in the office.
Next diagnosis,
Uh,
tennis
let's
elbow. It
let's
just
go
gets
let's
getting
go to
worse.
let's go to mucous cyst. We skipped that one.
Oh, yeah, same theme. Well, don't know if you can see mine.
Oh, God. So if you're not on YouTube, this is a reason to get on YouTube
It
and
is.
subscribe. You have to subscribe if you're getting to us on YouTube.
You do. We need YouTube subscribers. We need a few hundred more to reach a milestone.
Yes, we do. We want to reach the masses. And you can see Chuck's mucus cyst on his right index finger if you subscribe on YouTube.
Yes. Now, I don't believe in aspirating these, and maybe it's founded, maybe it's not founded. I worry about infection and creating an open track to the joint, and so I don't offer aspirations or injections. I don't. I'm very curious to learn if you do, but for me, if it's bothersome enough, surgical removal is my option for the patient.
Um, I don't. I think I list it in the list of options by telling the chances of it recurring are so high that it's probably not worth doing. I find many patients have quote lanced it on their own. So I
True.
mean, I guess your theoretical risk of infection is already there. It's there's already a track and nidus communicating to the joint. And I really do not get a lot of joy out of excising these, although I will and I do, and I probably do a couple a month, just because they come up. I do them Wallant, and I usually tell them there's always a possibility of a local rotational flap just because the cyst might look different and the overlying skin might look different on the day of the surgery. So just to avoid, because sometimes you see this pretty nasty skin ulceration that might make it hard to primarily close. Tell them it's coming from the joint underneath, which is typically inflamed or arthritic. We're getting rid of the cyst. We're not getting rid of the inflammation, and these have a nasty reputation for coming back.
Listen, all well said. Um, I don't have anything to add. I think it's most, it's interesting. A lot of people will hear me out and then walk out of the office, and then I may get a in-basket message or a call a couple weeks, couple months later, and they do want it excised. People are happy with the surgery. And you're right, it is an option to aspirate or inject, but not my first choice.
Okay, so as we start to bring things to a close, do you get excited about olecranon bursitis?
I don't, but it is one that I will carefully stick a needle in. I aspirate those and then I wrap them with an ace bandage. I warn patients that there is a super high chance of it coming back, but it is even lower on my list of things I like to operate on. So I will aspirate. I don't really inject. I think infection is a real concern here as well, at least for me. How do you think about it?
I do everything I can not to do anything.
So
I
you
think
start
this
with
is
it. I'm sorry.
I think this is where the Marty Boyer line of never miss an opportunity to do nothing is a perfect line. I don't like aspirating these. I certainly don't inject them, and I try everything I can not to operate on them. I think it's different if they're already having questionable signs of infection. That kind of forces your hand. But I've seen this go the wrong way so many times, where people who are very well intentioned have put a needle in it and created an infection, taken a sterile pocket of fluid, what I tell people, and introduced bacteria into it. I think that's a bigger risk for this than it is for the mucous cyst, or at least what the catastrophic complications can be. And then the surgeries that can go sideways pretty quickly. So I try to do everything from a wound healing perspective. We're fortunate that we have partners who are very skilled at flaps, but not everybody has that. So I try my best to counsel people out of doing anything for this.
Yeah, and if you do end up going to the operating room, it's not a small surgery. It's one that always seems much bigger than you recall. And this is not a once a year. This is a once every 3 to 4 years for me.
I hope it's a once every 10 years for me.
Have you done one?
I'm trying to remember if I did one. I think I did one because it was already infected and somebody needed to take care of it. And as Dr. Gelberman taught me and probably taught you, there's no passing the buck here at WashU. If we don't take care of it, nobody else will, at least in our region. So I took care of the patient. So the other topic on here was tennis elbow, and I think tennis elbow deserves its own episode. It's a condition that I don't enjoy very much, but it's incredibly common, and we should have a dedicated episode to that, to maybe a couple other conditions, including FCR tendonitis.
Yeah, and we could do medial epicondylitis. We could talk a little about PRP. We'll have to get a guest for that, but that could be a fun time. Fun time. That could be a really fun
Regenerative
time.
regenerative medicine.
Absolutely.
So your opportunity to suggest topics still exists. Email us at handpocast@gmail.com. Leave a 5-star review with a topic suggestion. Certainly helps us get the word out about the pod. And I hope everybody enjoyed this episode. We'll go through the survey and see if there are other episodes that aren't sports related that we could talk about.
Yeah, there's a large number of requests for sports and congenital. I'm just putting it out there. So.
Anthony told me that we had to pick a topic that both you and I would enjoy. So we picked this one for today.
Yeah, this was great. All right, great to see you. Have a good evening and get some rest.
All right, you too.